Now, types of ventilation. Now you have understood the reason. Now we have gone through what is required. Now we want to know the types of the ventilation. Two types of ventilation: invasive and non-invasive. Invasive ventilators through an endotracheal tube or tracheostomy tube. That means you're actually putting a tube inside the patient's body. A non-invasive is through a tight-fitted mask on the patient's face, and then you attach the ventilator circuit to this. So components of respiration which you can monitor on the ventilator. You can monitor the volume you're delivering, or you can control the volume, you can control the pressure, the oxygen delivered, the respiratory rate, the PEEP, the time, how much support you're giving to the patient, and flow and pattern, which we'll read in the next few slides. What is an iron lung? Currently, all the ventilators we use are positive pressure ventilators. When we started, it was an iron lung or a negative pressure ventilator, where the patient was kept inside an iron lung, and because of the changes of the pressure inside, it created a negative pressure which allowed the chest wall to expand, allowing air to rush in from outside. So it is also known as a tank ventilator or drinker tank, which was a type of a negative ventilator, no longer seen nowadays. In ventilator modes, you have two types of ventilators modes which are commonly used: the volume control or the pressure control. We will read about these later. Before we go into the modes of the ventilator, we should know the basic terminologies which we will be using to set modes of the ventilator. We have first the tidal volume. This is the volume of the gas that flows in and out of the chest during quiet breathing. And usually this is 6 to 8 ml per kg of an ideal body weight. So whenever you see a patient in front of you, try to calculate his ideal body weight from his height by this formula given. And then 6 to 8 ml per kg of that is adequate tidal volume for the patient. The minute ventilation is a total volume of gas entering the lungs per minute. It is usually the tidal volume into the respiratory rate and is expressed as liters per minute. And usually we target 6 to 10 liters per minute. The peak inspiratory pressure. This is the maximum pressure reached on inhalation. So you have, it is a function of compliance of the lung, thorax and airway resistance. Basically it has two components. It is a compliance of the thorax and the alveoli, and also you add the airway resistance of the ventilator circuit and the ET tube. The positive end expiratory pressure. The PEEP is designed to keep alveoli from collapsing at the end of expiration. The IE ratio refers to the relationship between the inspiratory time and the expiratory time. The normal IE ratio is 1:2. That is, if one part of the whole breath is an inspiration, two parts are in expiration. This is what you were saying. The peak inspiratory pressure, the plateau pressure. So the peak inspiratory pressure is a result of the airway resistance and the compliance of the lung. And the plateau pressure is more important because it remains in the lung for the longer time, and it is the alveolar transthoracic or alveolar pressure. This is the peak inspiratory pressure. The plateau pressure is measured at the end of the inspiration, and then you have the end expiratory or PEEP pressure. What is the FiO2? FiO2 is a fractional inspired oxygen. That is, where 100% oxygen is represented as 1. That how much percentage of oxygen is there in the inspired air. For example, if you have 21% oxygen in the room air, you will call the FiO2 as 0.21 and so on. The sensitivity and the trigger. The ventilator can sense the patient's demands for a breath, and it is usually expressed as the amount of negative pressure or change in flow. What is this trigger? It is what the ventilator senses or triggers the breath or starts the breath. So you have three components in a ventilator setting. You have something which starts the breath, which the ventilator recognizes. That's the trigger. There's something which stops the breath, that is a cycle, when the ventilator should stop the inflow of gases. And the last one is a limit. So we'll see all these things again. The start of the inflammation, when the ventilator recognizes the patient is trying to trigger a breath. This can be patient effort, which is known as pressure triggering, when the patient draws in air and there is a change in the pressure in the airways. Or if you're setting a rate in a controlled mandatory ventilation, it's time triggered, and after every set time, the ventilator itself will trigger into inspiration. And the last one is a flow triggering, where there is change in the flow in the expiratory circuit, which is recognized by the ventilator, and that triggers the inspiration. So we have pressure triggering, we have time triggering, and flow triggering. So, and what is pressure control? That is a parameter which controls the airway pressure. Once you control the airway pressure, you can also control the tidal volume because of that. That is like a limit. The ventilator will deliver the breath or the flow of gases till the pressure is reached, and that is why the tidal volume is achieved. What is a pressure support? It's a triggered spontaneous breaths are completed with the help of the pressure support. So the pressure support, the ventilator will, it's something like a support which the ventilator gives other than the mandatory ventilation. So once we have started it because of the triggers, when does the ventilator stop giving the inspiratory gases? The stop inflation, or we call it cycling, is by pressure. When a certain pressure is reached, when you set a pressure, that can stop the inflation. Or if you have set a tidal volume and that tidal volume is reached, that can stop the inflation, that is called volume cycle. Or if a particular flow is being reached, that can also call stop inflation. And if it is time cycle in controlled mandatory ventilation, when there is no effort on the patient's part, it can be purely time cycle, that after a particular time, the ventilator will automatically go into expiration phase and it will stop delivering the breath. This is what is pressure cycle. It terminates the breath at the preset peak inspiratory pressure. So this is directly related to the lung compliance. If the lung compliance is good, if you set low pressure also, you'll get enough tidal volume. If the lung compliance is poor, you'll have to set higher pressures to get adequate tidal volume. Volume, like I said, it stops at a preset tidal volume. Time cycle also.